So with that, I would say the question, I think that's the last thing I have on that. The question I would say is, we have these impressive results. This is not FDA approved here, but Keytruda is FDA approved in the post-surgery setting based on a trial that has results that don't particularly impress me. It's not that widely used. And I think the main question that I'm left with, but I'd welcome you to offer your thoughts, is, okay, we've been using, a lot of us, chemo with Opdivo for 3 cycles. Now we've got chemo with Keytruda for 4 cycles. The Opdivo approach doesn't have a specified post-treatment, post-surgery approach. You might stand pat, or you might feel like, well, we still probably need to do something. There's considerable risk of the cancer returning. Here you have that baked in, but we don't know if there's a real benefit to that additional nearly a year of immunotherapy after you and your cancer have already seen and received this, and it may be resistant. I come away with the conclusion that it's valuable to have the option, certainly as a baked in FDA approved option when it's FDA approved. I would have complete, what we'd call equipoise. I'd feel very comfortable with a patient making an informed decision about whether they want to pursue the post-surgery approach. If they want to cover everything that makes sense, great. It is real risk. And even if it came back, they would have the comfort of knowing they did everything that made sense. On the other hand, it's time, it's infusions, it's risk, and there's cost to a system. And I think people might reasonably say, I don't think it's that likely it would do more real good if my cancer was living through the first 4 cycles. So, Alfredo, what do you take from this and the relative value of the post-surgical approach on top of what they already got pre-surgery?
Yeah, I think, again, you sum it up beautifully. I think my take-home message is that there's no doubt that neoadjuvant chemoimmunotherapy is valuable. Now, we have seen not just one, but, several positive studies that showing whether you give a 3 cycle of chemo, whether you give 4 cycle of chemo with immuno, whether you give 3 cycle of chemo and immuno, and then you give 1 cycle of post-surgery, in the end, like the new torch study, in the end is still, is still positive. So there's definitely a benefit of adding immunotherapy in the early setting. Now, as far as the adjuvant part I'm concerned, that is tricky. And again, speaking as an European, so we might have limitation in terms of the approval, and I'm not sure we're going to have many options. And we might get the Checkmate 816 approved and not necessarily the Keynote 671. My main problem with the adjuvant part is, who do you give it to? Based on what? Based on the fact they didn't achieve a pathological complete response. But what if they had a major pathological complete response? Does that prevent them from relapse? Should you give a year pembro with all toxicity and cost? So I suspect, at least in Europe, and you might also have seen the EMA, which is the equivalent of the FDA, basically, that is trying to find some more specific biomarker to approve these treatment, and perhaps PD-L1 positive. It's criticizable. So I think at the moment, I think in Europe, we're going to stick with the neoadjuvant bit. So, 3 cycle. And I don't think we're going to go for the adjuvant treatment unless in the future we might have maybe some biomarker like MRD and ctDNA, so minimal residual disease.
And MRD is, minimal residual disease
by a blood test, which is not, ready yet. So I suspect in the near future, we're going to see a lot of neoadjuvant treatment with immuno. I don't think we're going to see a lot of adjuvant immunotherapy treatment in Europe.
Now, Christine, I'm really interested in your take on this. I highlighted the Keynote 671 trial. We also have a trial called Aegean with durvalumab, Imfinzi, very similar, not as mature follow-up, not as much follow-up, but very remarkably similar trial design. And then a trial called NeoTorch that Alfredo mentioned. This was a Chinese-only study with a drug toripalimab that we don't have available for lung cancer. But there's various choices, and you could do pre-op, post-op, or both. How do you put this together when you have a patient in your exam room and you can't just write an order for chemo with immunotherapy not otherwise specifying? You have to pick one. So what are you actually going to say for your patient who you see in your clinic?
Yeah, so I would say this is super complicated right now. So again, I'm gonna zoom out. I'm big into zooming out. So if you rewind the clock 5 years ago, every talk at this session that we're having now would have been for advanced disease, right? It would have been all for patients with metastatic lung cancer. So the fact that we're talking about screening, that we're talking about early stage disease, like stage 1, stage 2, surgical resected lung cancer, that's a huge win. There's new therapies for early stage lung cancer, so that's a win. So I want to start with that because I think that's just shows us that advances are coming. The waters are a little murky right now in terms of how we treat early stage lung cancer, and this is a great example. So there is huge enthusiasm in the field for neoadjuvant therapy or therapy, systemic therapy, infusional therapy before surgery, and adjuvant therapy, infusional therapy after surgery. When I'm seeing a patient and talking about this, I very honestly admit, listen, I'm going to be honest with you. This is a very rapidly evolving field. I don't have all the answers yet. Nobody has all the answers yet. I'm going to go through some of this with you. It's complicated. I'll tell you what's black and white, and I'll tell you where the shades of gray are. To me, what's black and white is that this requires a multidisciplinary conversation. That this is a conversation when we're thinking about neoadjuvant therapy. It requires a conversation that's not just me as the medical oncologist. It has to have a medical oncologist and a surgeon involved as well. This cannot be a one and done conversation. It requires a team approach. And that team, if you're listening, please, you need a team to take these approaches, because you need a surgeon, you need a medical oncologist, you may at some point in your disease course need a radiation oncologist. This is a very, very, very much a team-based approach. The second is, I think, understanding that medicine is not always black and white, that it's constantly evolving, and that the answers are not always right immediately in front of us. I think this is a great trial. I'm very enthusiastic about it. I share all of the concerns that you've already expressed. I think neoadjuvant therapy, in terms of how you coordinate it, and I want to acknowledge, this is not always so easy to coordinate too. A lot of patients see a surgeon first before they even see a medical oncologist, and they might go right to surgery. So, we have questions about who gets adjuvant therapy, but we also have questions about, who and how does a patient actually get neoadjuvant therapy, and how does that referral work? Like, what doctors does the patient see first? And so that's, I think, an important message about the multidisciplinary nature of lung cancer treatment, because neoadjuvant therapy will be, in my opinion, transformative for lung cancer care. I wish we had better biomarkers for who needs neoadjuvant, who needs adjuvant. I don't have all the answers now. I've been using what we call Checkmate 816, which is 2 different types of chemotherapy, plus a drug called Opdivo or nivolumab. I am comfortable using pembrolizumab or Keytruda because we use it for a lot of other lung cancer treatments as well. I have not yet used this particular regimen because we did not have this study at my institution, but I like having the flexibility of the option for the adjuvant or post-surgical therapy for patients who didn't have a complete pathological response or a major pathological response. The idea is, we didn't get all the tumor with the therapy before surgery, so maybe a little boost after surgery will be helpful. But I will freely acknowledge and have conversations with my patient that I cannot give you certainty that that's going to eradicate the tumor either. And we have to have just a lot of conversations about the ambiguities there, unfortunately. And so I think, as complicated as this is right now, that we will see this field evolve quickly over the next few years. And I will say that is desperately needed for us as providers, and even more so for patients, so that we can give them answers about how they're going to live their lives in the context of this complicated disease.
Well, given how rapidly this field has evolved, not just in the last few years, but literally in the last 3 months. We can look forward to having more to discuss about this in coming updates. So it's exciting. It's good to have tons of good options. I mean, we have more than we can use, but they are all positive trials. I think they just reinforce that doesn't matter which immunotherapy you use. Maybe the immunotherapy after surgery is icing on the cake. Maybe it's not necessary, but these are things we can hope to try to tease out what we can learn in the future. But all real advances.